Welcome everybody. This is Mercedes Byrne-Klug. I'm at the University of Iowa in the School of Social Work, and I'd like to welcome you to today's webinar. This is part of the Nursing Home Social Work Network's series, and you will see that the handouts from today will be posted on our website. I need to apologize that I did not get them posted ahead of time. But will be there immediately following today's session. I'd like to acknowledge the generous support from the Retirement Research Foundation for making these webinars possible. Our webinar series is dedicated to building knowledge and skills of nursing home social workers and social service staff members, but we make these webinars available to everybody. So anybody who's working in a nursing home setting or interested in the nursing home setting or a student of the nursing home setting, you are welcome. And just know that. We do have speakers who are social workers, and we also did into other disciplines for certain topics as well. We are inviting bachelor's level social workers who are currently working in a nursing home to share a case from the field with us. If you're at all interested in sharing a case, which is like a paragraph and a half describing a real situation in your nursing home, just contact me later and we'll talk you through how to do that. We are able to email people certificates of attendance who, if you're part of this webinar, because when you registered, you gave your email, and when you fit today, you'll get an evaluation form, and it'll ask if you want a certificate of attendance. And so we'll be emailing those to the people who attend today. We'll put your name on the certificate of attendance, and then we also put how many minutes you were part of the session, because that's all being recorded also. We have not asked for CEUs, so in some states they'll take that letter of a certificate of attendance and accept it towards CEUs. Other states will not. That will be up to each individual social worker to figure that out. So if you can't hear what I'm saying, or if things get fuzzy or anything like that, please give me a little message in the chat box, and I will try to work with you so that you can completely enjoy today's session. It's being recorded, and the recording will be posted within about 24 hours on the website, available to the public, no cost. So we're going to start out with a welcome, which I'm doing right now, and then I'm going to hand the mic over to my colleague, Deirdre Downs, who will be introducing the topic and the speakers, and our speakers will present their topic. And we're going to reserve about 15 minutes. So by 4 o'clock Eastern time, our presenters will finish up, and we will have the last 15 minutes, so from 4 to 4:15 Eastern time, with questions from the audience. And when I say questions from the audience, I mean you'll be typing in your questions in the Q&A box or in the chat box, and I'll read the questions for everyone, and we can go from there. So that's how we're going to be doing it. I'd like to turn the microphone over to Deirdre Downs. Now, she's the Director of Social Services at the Jewish Home Life Care in New York City, and she'll be introducing the topic and our speakers.
Merce. Welcome, everyone. So I'm pleased to introduce the topic today is person-centered care, the dignity and challenges of resident choice. Our presenters are Christa, Hojlo, and Rees, Gavin, and Term Services and Supports, the Director of the VA Community Living Center. Okay, so is the Director of VA Community Living Centers at the Department of Veterans Affairs. A licensed nursing home administrator, she has led, guided, and directed significant transformation in the delivery of care to frail and functionally impaired veterans in community living centers nationally, and has set a vision for care in state veterans' homes. She holds a bachelor's degree in nursing from the University of San Francisco and a master's degree as an adult nurse practitioner and a PhD from the Catholic University of America. She is a licensed nursing home administrator in the state of our presenter. Second presenter is Molly Rees Gavin, president of Connecticut Community Care, Inc. She began with Connecticut Community Care, Inc. as a processor in 1976, a demonstration project to help people remain in their homes than being admitted prematurely to a skilled nursing facility. CCI is now a statewide nonprofit organization offering community services to elder and adults with disabilities at home. Prior to CCI, Molly was a medical social worker at Hartford Hospital on neurosurgical and neurology units and a psychiatric social worker at Trenton Psychiatric Hospital. She received her bachelor's degree from the University of St. Joseph, West Hartford, Connecticut, and master's in social work from Rutgers, the State University of Jersey. So welcome to our presenters. We're looking forward to hear the president this afternoon.
Hey everybody, this is Molly speaking now, and I wanted to welcome you. And I can tell from looking at my computer screen that there are approximately 3 of us on the call. So if fourth are the panelists, then that means that there's 9 of you listening. So thank you very much for being here. Our expectations of what you hope to get out of this webinar today is an understanding of the history of the culture change movement in skilled nursing facilities, with a particular emphasis on the person-centered care aspects of this. And we also hope that you'll be able to incorporate the principles of person-centered care, which we intend to review, into your practice, and that you learn effective tools to enhance person-centered care in your own facilities. So with no further ado, let's move ahead with our presentation and move on past our objectives to thank you very much for participating today, as I already said, and also to tell you, and I do not say this in a gratuitous manner whatsoever, but to thank you for what you are doing as social work practitioners, what I consider to be cutting-edge social work positions regarding culture change, where the rubber really is meeting the road. Each and every one of you, as a social worker in a skilled nursing facility, made the decision to give up an hour and 15 minutes of your time today, to take that time away from your consumers, perhaps to take it away from your own children and family in order to participate. And you are in a social role that is very, very, very challenging, where you often feel like you are the only person who is the voice for person-centeredness. And I want you to know how much all of us appreciate what you're doing and hope that this webinar is helpful to you in some small way. So I'm going to spend a little bit of time, and I say to my colleague Christa, obviously Christa and I aren't in the same location, but Christa, know that I hope that you'll jump in anywhere along the way where you might want to add any content. But I wanted to start with, how did we get to where we are with the culture change movement? Because I believe that our history as social workers in skilled nursing facilities, it's very important for us to understand the history and the framework of how we got to where we are today. So my first bullet starts at 1980. I'd really take us back to the 1960s, and of course you all know that Medicare and Medicaid were enacted in the United States in 1965, 1966, under Lyndon Johnson administration. And what was very important about Medicare and Medicaid, well, there were many things, obviously, that were very important, but it was the first time in our country where there was a very foundational opportunity to pay for services in skilled nursing facilities. And so what happened was that from the early 60s to the late 60s, we saw an exponential growth in the skilled nursing facility industry in the United States. Unprecedented growth in this industry in every state in the union. And in the mid-1970s, we saw the recognition by early advocates that not all skilled nursing facilities were necessarily operating in the best interest of the individual. And that's not, please don't think I'm saying that about every facility. I'm certainly not. I am saying that we learned through a number of books that comes to mind immediately was the work that was done by the name of George Polk. And in 1974, he wrote a book that was called Tender Loving Greed. And it was really, that was the beginning of the recognition that there were financial interests as well as person-centered interests that drove nursing facility care. And really, in the 1970s and the 1980s, consumer advocacy groups began to expose some of these issues in some skilled nursing facilities. In 1986, 1987, the United States Congress enacted sweeping legislative reform. You may have heard the terminology before, the Omnibus Reconciliation Act. Basically, one aspect of that really encouraged individualized care. And 10 years later, the pioneer group coalesced in the United States to advocate for what came to be known as person-centered care and, quote, culture change. Christa, do you have anything you would like to add to that history from your perspective? Hearing Christa. Hopefully I'm still, the rest of you are hearing me loud and clear. We seem to have had...
Yeah, I'm hearing you fine, Molly.
Yeah,
we don't...
Molly, I was trying to unmute.
Okay, go ahead, Christa.
I'll make a comment. I think sometimes we get caught up in that terminology, culture change and pioneer network, and this is all this esoteric stuff that we really can't do. And we really think about it, and I believe that social workers are in a prime leadership role to be able to do this. What we're really talking about in nursing home care in this country is transforming the way we think about the way we deliver services in these facilities. What does person-centered really mean? Person-centered really means person-centered. It's, attention to, in a care plan meeting, for example, if somebody's having behavior challenges, one of the first questions you want to ask is, what's their normal sleep-wake cycle, and are we waking them up at 6 o'clock in the morning? Well, they really, like Christa, like to sleep until 10. The space is really clear. People do better when their sleep-wake cycle is normal. So it's really nothing more than helping transform the way people think of the way care is delivered and asking questions, well, why do we have to continue to do it this way?
Right. So what's so important about what you're adding, Christa, is that it helps us to see that this is something that each of us have the potential to do where we are working today.
Yes.
So let me move ahead to some of the principles of person-centered care and ask that you consider, this is directly following up on Chris's comment about that, to talk about what do we really mean by person-centered care. And we're looking at the opportunity for each resident to exercise as much autonomy, direction, and choice as he or she wants to have. Autonomy, direction, and choice, for opportunities for resident engagement, enhancing the quality of life. So that residents will be able to engage in relationships with assistant staff, with individuals who know them, who have experience working with them, and as a result of that experience, that these individuals are able to recognize changes in individuals' circumstances and conditions. We are looking for a resident life that is meaningful, that individual, and finally, that we are developing an environment of trust and respect. And my perspective, those 5 elements are the basic and principles of person-centered care. Christa, are there examples that you would like to share with us, or anything you would like to say about that?
I think when you talk about lives being meaningful, again, a new way of thinking, the average ordinary nurse home staffing. So they staff somewhere around, let's say, 3.0 nursing hours per patient day, maybe 3.5, meaning that in the course of 24 hours, the person really only requires or gets 3 to 3.5, maybe 4 hours in 24 hours of nursing care. That's the requirement in 24 hours. Then they sleep maybe 8 hours, and then they eat another 3 hours. So you add all those things up, and really like, let's see, 8, 10, 11, 12, 13, 14, 15, maybe 15 or 16 hours of something directly done, time that's allocated for certain activities. What's with the remainder of the day? Well, what happens in the average ordinary nursing home in this country is that people are put into a wheelchair in the hallway or in a dining area or in front of the nurse station, and they're feeling the rest of the day. Now, our activities program, but I call sometimes Bible, bingo, and birthday. So what we have to do is look at what is meaningful to an individual. How can their day become more meaningful? What can we do? How can we bring life to that day that is more than Bible, bingo, and birthdays, and then the things that are done in the course of the day? So that's one area where social work can certainly be created in how you interview staff, how you interview residents, how you interview housekeeping staff, how you interview families. Just little clues about who is this person, because that's really what's missing in our care. Let me turn it to you, Molly.
Christa, thank you. Moving ahead to how we bring about change. And, Christa and I talked about this at great length because we understand the fact that each and every one of you on this call is one individual working in a skilled nursing facility where you may not feel that you exercise the power or privilege to bring about change. And I challenge all of us to recognize that there are things that each of us can do in our own tiny sphere of influence that will enhance person-centeredness. So I'll start by saying that, start by saying that the kind of easiest thing to do is work. Just have done our homework in school. And frankly, you're all doing that right now by even participating in this webinar. So you want to do a little bit of reading, a little bit of exploration, the various aspects of person-centeredness. In anticipation and preparation for this webinar, I obviously got on the internet. I plugged in, I typed in person-centeredness, and I was bombarded by a very rich array of materials on person-centeredness that I found very helpful. And I'm sure that if you do the same thing, you'll see that some of that information is the same information that Christa and I are sharing with you on this webinar. A second recommendation I have, and again, this may sound trite, but I don't believe it is, to carefully identify your allies in your skilled nursing facility.
Wait, let me interrupt you there. I want to second that. That is absolutely true. You need to know who your I call it secret partner or your secret Santa, whatever it is in your organization, so that you have someone that you can run these things by and can support. You can support each other, because that's one person can make a change, but 2 or 3 people who are allies. And we'll talk about language later on. That's huge. That's really a huge piece of it.
I don't consider that interesting at all. Thank you very much. I know how important I have found the careful identification of allies throughout my entire professional career. And in some facilities, every worker in the facility, if there are more than one, may be an ally. In cases, you're only social worker there, or other social workers in your department don't share your enthusiasm about person-centeredness. In some facilities, the director of nurses may be an ally. In other facility, that's not the case. In some facilities, you will see physical therapists and occupational therapists. These concepts of person-centeredness may or may not. So it's really important for you. Everybody needs a friend. So as Christa said, one person can do it. It's a lot more supportive of 2 or 3 people working on this together. And that leads me to my third comment about how we bring about change, and that is the whole idea of really starting out small. We know that Rome wasn't built in a day, as the saying goes, and that change is challenging to individuals, to institutions. Change is not always positively received. And so we start small, one tiny step at a time. We individually or collectively with our allies, we figure out one little thing that we are going to try to do, and then we're going to grow our efforts from there. We're going to educate ourselves and to educate others on person-centered change. And let's remember that sometimes our best allies may be our individual patients, consumers, our individuals, and their families. That if we can't do anything else, we can role model appropriate behavior. As Christa said earlier, we can be the ones to give voice to the individual's goals and the individual's objectives. We can be the ones to say, would you like me to call you Ms. Smith, or do you prefer that I address you by another name? Sounds so trite and so small, but have been in situations where a person in a skilled nursing facility is called by their first name, or is called Honey or D, hasn't heard the title Ms. Smith or Mr. Smith in years. So of a very dignified elder who was a minister around his church for his entire life. And when he was in a skilled nursing facility for a time at the end of his life, called him Lou. It was Lou, Reverend Lewis, so-and-so. People would call him Lou. No one ever called that man Lou for the rest of his life. People called him Reverend, not Lou. So just a tiny example of how we can role model appropriate behavior, whether or not we can get anybody else to join us in that or not. Christa, do you have any additional thoughts you want to add about that before I go on?
Excellent points and excellent examples. Thank you.
Okay, so then again, moving ahead with how we bring about change, we always need to be able to be advocates. We can advocate for change. And the final thing I would mention about that is that we need to identify and celebrate our successes. And I can't say that strongly enough. If you spent a month asking people how they would like to be addressed, and the next thing you know, you hear a nurse on the floor doing the same thing, or you hear another colleague, give yourself a pat on the back. You have brought about social change in that facility. And the thing I feel very strongly about, and Christa mentioned this earlier, is that the thing that we are talking about right here and right now, colleagues, these are social work skills. These are skills that we as social work professionals bring to this setting in a way that our nursing, therapists, and medical colleagues not necessarily bring the same skills forward. So we need to work very hard in helping the consumer, in helping the person in the identification of their personal goals. And I have heard Connecticut care managers tell exquisite stories about working with individuals where the medical goal was to reduce the person's high blood pressure, where the medical goal was to reduce the person's cholesterol. And if you spoke to that individual person, one example haunts me is an interview with an individual where the professional social worker posed to the individual resident, what was the individual's goal? It didn't take 30 seconds for that person to say, my grandson is graduating from high school in Milwaukee, Wisconsin in 6 months. And the only thing in the world that matters to me is able to attend the graduation. Didn't articulate blood pressure, diabetes, any number of physical issues as his goals. His goal was to get to that graduation. And that staff put together a plan that, of course, indirectly included what the goals were, but were person-centered. The goal was graduation 23rd, 2013, and how to attend that graduation. We always keep the individual at the center of the care planning and the decision-making process, as that previous example suggests. Social workers are skilled at motivational interviewing techniques. We know how to engage in active and in reflective listening. We know how to pay attention to what the person is saying, but not only what they're saying, to be concentrating on their affect, on their behavior, on the intensity of their speech, and we are able to reflect back that individual what we are hearing in terms of what is important to them. These are clearly our social work skills, and we can use them on a daily basis in supporting person-centered care within skilled nursing facilities. I am now going to turn the program over to my colleague, Christa, and Christa is going to look at these same issues, but from a slightly different perspective. So we're going to twist the scope 180 degrees and turn this over to Christa.
We're very much on the same wavelength here. One of the things that I like to talk about a lot is language. Because actually, when we talk about, there are tools that measure culture change, and there's a really good tool out there called the artifacts of culture change. You say that's a silly name for a tool. Well, the fact of the matter is it measures those elements that are, really is inside of us. It's studying those artifacts that shape us, and which is clear evidence of, it is an artifact that evidences about who we are, and how we function in a particular culture. So we work in a cultural framework that was traditionally the medical model. And to use language like nursing home. So in VA, we changed that language. We don't call our nursing facilities nursing homes anymore. We call them community living centers. The whole system of nursing homes across the United States, we call them community living centers. And the entire healthcare system, which is one of the largest healthcare systems in the country, having now calls them CLC, community living centers. But if I asked you to draw and asked you to draw something like community living centers, you draw. We do art out of the culture that certain language communicates. To draw probably sterile, boring, and hospital-like. Although nursing homes today are really trying to step up a little bit, but still, there's a negative stereotype, and that's probably what he would draw, what most people would draw. So if I had to draw a community living center, your residents in that picture would even look very different, which is very important. Then we talk about placement. Where to put the person for 90 days of skill care, and then where we're going to put her. We have to stop being people. We have to stop talking about placement. We need to start talking about what is this person's destination. And so that destination is home. If the nursing facility is our home for the rest of our lives, we have to reassess that. Use your section Q. Use the MDS. MDS is a great tool. Look at Q, and you always ask the question, what is this person's destination? Is there any possibility that they might be able to do this another way? Are there services and supports outside of this particular facility that we can and there are more services and supports available from the community where they actually be able to go back to their home. Finally, medical diagnosis, a framework for placement. I mentioned hypertension. Well, when you pick up a lot of care plans, we're trying away from this in VA. I don't want to see on a care plan hypertension as evidenced by blood pressure at 40 over 70 when their blood pressure has been high for years and years and years. Never going to go lower. It's reached 170 over 60 or 70. What it is that the norm is, whatever that norm is, it's never going to get there. So we're going to, the diabetes will be under control. Well, they don't care, and there's some new guidelines on diabetes anyway. We don't have to be doing finger sticks on everybody all the time, and there's a hemoglobin A1C that we now have, the new evidence base has changed. So that's what we really need to look at. And you don't have to be order special diets for the majority of people who are in nursing facilities. If your food service orders or is committed to good food that tastes good, you can reduce the sodium and sugar and junk in it. You don't really have to have people on special diets. And actually, there's even some new research out about diets and those kinds of things. There are approaches to those. Person-centered approaches. What if I really do want a hot dog and that means something to me? And there's a risk of choking. How do we deal with that? There are ethics consults. So the medical diagnosis should not be the rationale for placement or putting people anywhere. There is new language coming out now, the Affordable Care Act, CMS, Medicaid, all those folks are talking about long-term services and support for person-centered care. And they're also including nursing facilities as long-term services and support. Well, given VA, my organization, an opportunity to say, wait a minute, if nursing home is considered a service or a support, I'm asking different questions on admission. And social work, in many instances, has an opportunity to have a voice here. And the question on admission is not what is their diagnosis. The question is, why are they here? What are they coming for? What services? The living facility should not be looked on as a living, as a house, as a household. Well, we want it to be an environment, but it's not meant to be for spending the rest of your life if that's not necessary. We need to reconceptualize the fact nursing home is there to provide certain services and supports that can't be provided, facilitate this person's everywhere else. So let's talk about what services this person needs. They have their hypertension, they're going to have their diabetes. That can be treated on an outpatient basis. There are thousands of I don't need this in hypertension, fortunately. But, many of us go see our physicians for something chronic all the time. It doesn't necessarily go away. It might get better controlled so that we can longer. But really what happens to us over time is that we lose our ability to care for ourselves. We lose function. And so that's what we really should be looking at in our facilities. What was it that this person needs from us in order to thrive? Either because that's a Kaiser logo. Will I have a comment about this?
I'm Christa. I'm fascinated, and I'm with you 100%. Thank you.
Well, one of the slides that you will see is a woman. Too many pictures in my slides this time, but a woman that's dressed very nicely and has her hand in her head, kind of in this worried position, and the caption is, "Oh my, no, I will not be put there." Isn't that what most people fear? It's the putting there, and the notion of being put there not to receive a service, but being put there lives in instead of put away. So we have to change the putting language. We have to change the medical model, the medical language. Legal language, this likes to be, this is our diagnosis. Like, I'll tell you, I had breast cancer in 1999. It was stage 3, and I made it through chemo and all that. But I thought, people will say, well, you're a cancer survivor. Well, no, I am a full life human, and cancer is something that I have had to deal with, and I may still have cancer cells inside my body. I did not wage war against my cancer. I owned it, and I am not my cancer. I'm not going to be defined by having had cancer. So the same thing with a diabetic or anybody. We don't want to define people by their disease, because then they're behaving like their disease. We're giving people tools by the way we find them. The first thing we say at care planning meeting is, this is or Miss Smith, 72, diabetic, schizophrenic, broke her leg, blah, 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 blah. And so we have this list of diagnoses. The fact of the matter is, who the hell cares? Spectacular. What people need nursing home care for, institutional care for, not all those diagnoses. Those are never going to be fixed. They'll be issued by physicians. But they're because saying something else in order to maintain the ability to live as fully as possible. Some of these folks, notion of highest practicable level of well-being, over language, for the fact even since comatose, that person will wake up. But practicable level of well-being for that person is that they are pain-free, that they don't develop a throat ulcer, that they have soothing music playing in their ears, that they have people coming in and sitting beside them and speaking to them even though they can't respond. That, like, I'm a person who likes light. I like my windows made up all the time, and I like a lot. So if I'm comatose, I want light around me. Highest practicable level of well-being. It's not about cure. And so you as social workers can discover who that person is and discover that they're not the diagnosis and actually be that voice for that person in care. Because you're always focused on the diagnosis. And that's okay. That's change.
And Christa, to your example, I mean, I'm so struck. I was just going to add about the role of social work in that kind of a setting. I think about that, the beginning of the litany of the 9-year-old status post, blah blah blah, this condition and that condition, and that's where if the social worker had already had the opportunity to conduct a thorough person-centered interview with the resident and, if appropriate, with their loved ones, that is the exact moment in time when that social worker can begin to talk about the things that they are important to this person. So, let the person go on about the diagnoses and the this and the that, and then you're able to, then that's where you can talk about the fact that the individual's, spouse died 6 months ago, and they had married for 60 years, and that the individual is having difficulty coping with that from a financial perspective, from a behavioral perspective. You could talk about that. You could talk about what supports did the person have remaining in their life, that none of their children live locally or they didn't have any children, that they are very involved with have been involved with the Retired Teachers Association or with their church group, and that you're trying to identify sources of support. That would be the place where a social worker would be able to take a deep breath and very bravely bring another perspective to that conversation.
Right target. And, an additional question that often comes up, it can come up, that people ask is that, so you're here now, what is this like for you? What does this mean for you? Discover what the meaning of this, somebody used the word used there, meaning of this quote placement for you. They can start articulating losses if they have them, or their dreams that we want to go home. Well, let's not dispel that notion. What is it that might need to happen for you to be able to go there? I've said this to you talk about this in clinical settings a lot. Don't ever tell a person they're never going to go home. We do that. Discover what home means for them, and then look for ways, in any steps, what they think they might contribute to improving their circumstances while they're here to make it towards that goal. But this goal is so depressing to people. But giving them the opportunity to try to walk more or eat a little better or take their medicine toward that goal, because we never know really be there for them that they might be able to do that. So it's part of that where have somebody lose hope if you can, but discovering what is the meaning of this transfer into this facility time is a really important piece of understanding who the person is. And again,
Christa, another thing that I've learned about this over the years as well is how helpful it can be in ongoing intention of interviewing the person to identify what are the elements of home that person experiences as not having, to really dig down into what exactly does home mean to that person, because I think we all have a tendency to realize that we all know what people mean when they mean home, that we all know the warm, fuzzy feeling of there's no place like home for the holidays, that we all know what that means. And I think that we can learn tremendously from our residents if we're really attempting to identify what they mean by home, because it is possible that some of those aspects can be introduced into the current setting, even temporarily, until they do go, quote, home.
Absolutely. And people might tell you, the smell of fresh bread or something like that. And there is much more possible today in nursing facilities than there was in the past. And so that's a really important point, and I appreciate you bringing that up, because that's critical to this. We talked about the fact that the diagnosis is not everything, actually, but the diagnosis can give us clues to what the person might need to be able to function. It can impact how the person functions. We have to understand if they've had a stroke, for example, there's a major change in their ability to get under or do certain things for themselves. And one of the first things, this as social workers, to explore is, again, what is this like for you? This must be very difficult. Tell me about this. What does this mean to you that you can't, pick up a brush by hand anymore and comb your hair? Exploring those things. And then this you can get a creative PT and OT, and again, if you can discover what this means, the person verbalizes it and then start working with the other hand to improve. I think you know all these things, but for some reason, you're able to coalesce as together, surely use the information that we have to do care planning and help us think differently about the way we deliver care to residents in facilities. I've kind of summarized a lot of my slides. There is, I'll make a summary statement, and it's in one of my slides called New Imperative. And the new imperative is type of services needed for the right amount of time and in the right venue. Sometimes the nursing home is the right place for a lot of time for a particular reason. Q in the MDS keeps reminding us that we have to constantly ask the question, is this the only place this person can receive these services? Boards are important to assess the impact of the medical condition on the person's ability to do ADLs and IADLs. You know what those are. What specific interventions are needed, such as wound care, physical therapy, that might person to a point they might be able to function at a higher level and maybe even go home. What's the person's personal history? And social workers are privy to a lot of this information in ways that many other professionals, including physicians, are not. One time, there was only venue for services, and that was nursing home. But that's no longer the only game in town. There are so many other venues for care, for home and community-based care. And I urge you as social workers to also always be conscious, and many of you I know are. We don't, however, in practice. I would encourage you to continue to raise your consciousness beyond the facility and discover there are PACE programs for all-inclusive care for the elderly. There are congregate living facilities. There are so many options in the community that actually can be a source of hope for you who really doesn't like being in the nursing facility and wants to be someplace else. So to take Section 8 in Section 2 in the MDS very seriously. With that, Molly, I wanted to see if you have any other comments. I think I'm going to stop and maybe have time for some more discussion with the audience.
Yeah, my only other comment is that, Chris, and I know we're on the same page with this, that really we want the individual participants on this webinar to leave the webinar feeling empowered that there is something that they can do. As I said earlier, obviously, people wouldn't have given up their hour and 15 minutes to be on this webinar if they didn't believe in this concept. So even as we say that, I also want to share the fact that if people are feeling incredibly frustrated, that frustration is understandable. And one of the many articles that I read in prepping for this webinar, actually not an article, it was an article in Fortune magazine or something like that about person-centered, Forbes magazine, excuse me, about this new concept of person-centered care. And somebody sent a letter into the editor, a nurse who worked in this skilled nursing facility, and she took exception with the tone of the article, which had kind of intimated that physicians and nurses and social workers really didn't care about person-centered care, that it was kind of new lingo and new jargon, and she took strong exception to that. And she said that the challenge is that we're not financed in a way that is providing us with the opportunity to spend the time with the individual, to conduct the kind of interviews that we would like to conduct, to provide the kind of opportunities that we would like to provide, and that we would all be doing it if we had the financial wherewithal to be able to do it. And so I didn't want people on the to think that you and I are, kind of pie-in-the-sky idealists. I understand how very challenging this is. I understand that there is tremendous turnover in the skilled nursing facility social work positions because of some of this frustration. And I simply wanted to acknowledge, Christa, that you and I both are very well aware of that.
Yeah, thank you, Mike. I think that too is an important point. Watch the struggles in our system, and people sometimes, even if people have the time, they will say no. So it's really really getting into yourself and understanding what it is that you can do, even like what we said earlier, on a very small scale. The other thing is, please don't take this as an advertisement. I don't want to be perceived as somebody advertising on a national call. But Molly mentioned the Pioneer Network. I would highly encourage you to connect with them. Unfortunately, the Pioneer Network is not blessed with as many social workers participating as what I wish it had, because you have you've got a set of skills very unique that actually be helpful to help the code change happen. I don't know if any of you know Carter Williams. She is the wife of T. Franklin Williams, who was the first, he's not the father of geriatrics, is a social worker. She's in it now. And her actually was one of the founding members of the Pioneer Network. And she actually convenes the Pioneer Network every year, and this past year, she herself has become functionally somewhat impaired, where her ability to travel is no longer what it used to be, and so she wasn't able to attend in person, and so she still convened the meeting via communication. It's like over 1,000 participants annually. The next one's in Kansas City, and you can look it up on the website, pioneernetwork.net or .org, probably .org. But you have a lot to contribute, and what happens at Pioneer Network is there's an energy that is generated, but also a camaraderie that's built up. I come just about every year, have developed a sense of this is where I get my strength to effectuate this. And what I want to share with you is that I work for the Department of Veterans Affairs, which is national health system. As I said earlier, it's in the federal government. Now, government stuff is black and white. Now, what can I say? But I have been successful in getting this organization, what I call sterile, sometimes, the images that people have about federal government. We're building the small greenhouses, actually doing some of these things. And it boggles my mind to think that we're doing this, but I get my strength as a national leader, community living centers, to do this from interacting with people that through different associations and definitely the philosophy and impetus in Pioneer Network. So I would encourage you to get involved. Molly talked about reading and networking already, but I just want to really encourage that even more.
I second that, Christa, because again, I am struck by the fact that the 35-plus people who are on this call have a real commitment to this issue, and I realize it varies state to state, but most states, if not all, have a chapter of the National Association of Social Workers in the state. National Association of Social Workers state chapters often have aging subcommittees, or committees on aging or something to that effect, committees health care, and it would be worth it because we all need the support of others in kind of change. And NHSW might be a potential place in your state, in addition to Christa's excellent recommendation about the Pioneer Network. You'll be able to start a local group of nursing facility social workers on this exact agenda.
Yeah.
I'm glad that it's 4:59, so Mercedes may want us to move into questions and answers.
I appreciate that. Thank you so much, Molly and Christa, for sharing your insights and your ideas and for packaging this information in a way that makes it easy to listen to and also highly motivating. I'd like to invite people to go ahead and type a question into the chat box or the Q&A box, and I will read questions for the whole group. We have a question that has come in from Tina. Tina asks, can one of you speak to the issue how best to address the topic when resident choices pose risks to their health that medical professionals are opposed to?
Well, that's the nub of the issue there, Tina. Christa, do you want to go first, or how do you want to handle that?
Well, I'll take a stab at it, but
okay.
There is several movements in the healthcare industry today, and in healthcare, and EMS, by the way, that are suggesting that other than physician-assisted suicide, where you're actually, killing somebody, at request. Use dietary things, medication, administration. Those are the two areas that are the most common. Falls. How tiny, I want to be able to take the risk of possibly, falling. I have to understand who the resident is and where the resident is coming from. It's to document those conversations, and sometimes it's even important to take next steps and get an ethical consult to have some of these questions on what it is that we're talking about. It's as simple as, I want a hot dog. I don't want that pureed food. The person cognitively intact somehow is able to communicate that they don't pureed food. And there's some new literature out on that too. It's always important to go to the evidence base. Here's another evidence base. I think it's important to disturb people's sleep-wake cycle by giving them 2 hours pressure ulcer care in the middle of the night, 27 days a week. The new literature, the new evidence base, is showing that it's more important for healing that the person gets the sleep they need and treatment later on. I want to leave somebody sobbing wet in a bed, particularly if they have pressure ulcer. On the other hand, I'll make an agreement that we're not going to wake you. We'll wake you up at your normal time, blah, blah, blah. But so I don't think I get an answer today because there's no real good answer. And you might want to have this topic discussed by some experts in the field at a future meeting. But I would say go to the literature, talk to some ethics people, but take the answer that, well, this is probably for their health, therefore we should, we have to do something they don't want us to do. The question very often is, what would this person do if they were at home? Physician-assisted suicide. That topic, again, that I think is beyond the reach of, where most of us really need to go. But it's in the mundane, everyday things.
The thing I'm thinking about, Christa and team, this is one of the central issues, of course, you've identified in terms of person-centered care. And certainly we at Connecticut Community Care, one of the things that we work on with our state agency partners is the whole concept of negotiated risk, the whole concept of how can we reach a compromise on this? And one thought I have is, again, this might be an opportunity, Tina and others, for you to try to pull together a couple of allies, maybe not in the heat of the moment when there is a particular discussion going on about a particular resident, but to suggest that maybe some of you could sit down over a brown bag lunch and talk about negotiated risk. Maybe you could recommend one article that everybody read, and could we all sit down and talk about this? Or could a few of us sit down and talk about it and begin to bring the language of negotiated risk and negotiated risk opportunities forward? I think it will be very incremental. It will really depend on the personalities and the staff of in your facility. People are very concerned about liability, unfortunately, way more than, frankly, I think is helpful in this circumstance. But everybody is seeing a lawsuit around the corner, and there may be local experts in your community who discuss negotiated risk, local attorneys who do that, where perhaps someone would come and provide an hour presentation to your staff. I'm just brainstorming here, but I'm acknowledging the criticality of the issue, and I'm thinking that you want to start the conversation about negotiated risk in your facility. What do you think, Christa?
I think the fact that you even brought it up is a good sign.
Yeah.
it is being discussed in wide forums, as I suggested. So tap into some of those.
Yeah.
All right. We have another question that has come in. This is from Evelyn. What happens person-centered care for someone who already is heavy set and a choice of food that it's not recommended by dietary, and the person becomes so large it's difficult to take care of her safely?
Well, the questions and answers are never easy, are they? That's a very, very, very compelling example, Evelyn. And again, you know, from the Molly and from my perspective, again, it really does back to the negotiated risk. So the individual, if we are talking about a person who is considered to be competent to make their own decisions and they are making lifestyle or food choices that are not in their best interest, from my perspective, they have the right to do that. And this is the overlay to this is the double-decker challenge of the fact that it becomes difficult to care for this individual as a result of this choice. And I don't doubt that is an additional challenge. I don't think it takes away from the person's right to make that choice. The person needs to understand that they will maybe compromising their care as a result of that choice. But I see that as a pretty clear-cut example of individual choice. What do you think, Christa?
Well, I see it that way too. It's very difficult to watch this. It's difficult to watch somebody make some of us consider bad choices. I make bad choices on a daily basis too, not that particular one, but when I think about some of the I've made, somebody could look at them and say, well, Christa, you're making a bad choice here. It's what's the bad choice for me, and the thing is that I often have a rationale for why I'm making a bad choice. And so the obese person. So if they're to explore that, I said earlier, there are ways of making food very desirable, and the facility has to be committed to be willing to do this. Their facilities say, oh, food's expensive. But there are ways of making food desirable and tasty, but low in calories. At the same time that people should have 24/7 access to food. They're caught between a rock and a hard place, and it comes down to individual choice.
Things you've mentioned in the last two questions, the whole concept of negotiated risk and having those conversations. And I think it's important to have the conversations in the way the conversation is had is going to be important as well. So making sure that it's done in a respectful way and that people feel heard, including the staff, the family members if present, and then the people living there receiving the care. So that's important. And then the other issue was cognitive competence or decision-making capacity. And as long as people can make their own decisions and understand the consequences of those decisions, you're right. We make poor decisions. Adults make poor decisions every day. The other point, though, it hinted through the question was this is a group setting, and others are affected by decisions, and so it is a delicate balance to make sure that everybody's voice is heard and that decisions are made that are in the best interest of the resident, even though it is a group setting.
And I also think sometimes we expect people to move on what we recommend too quickly. Yes. I mean, a person has been living their life a certain way, we are a brand new actor in their life play. Why they listen to us the first time that they met us? I mean, picture this as the kind of a situation where over many weeks and possibly months, intervention on behalf of that social worker, that individual might be willing to change. That individual might be willing to consider another position on something, but not when they met us.
That's true. We have another question that's come in. What do you do when you see or when you hear a social worker or nurse bad-mouthing a patient while in their presence?
Well, for example, I am walking by or seeing a social worker down the resident in the resident's presence. Please again.
The question is, what do you do when you see or hear a social worker or nurse bad-mouthing or being disrespectful to the patient while in their presence? So it's not clear who the there is. Well, let's just assume it's the situation where you're walking by and you overhear the social worker bad-mouthing a patient, or a person bad-mouthing a person, the act of bad-mouthing a person, and you're walking by.
In front of the person? In front of the person?
A clarification came in. I was walking by. So, Toya, are you saying that the staff member was bad-mouthing the person right in there and you happened to walk by and witness that? Let's just take it that way.
Yes.
She says yes.
Yes. So from go ahead, Christa. I'm sorry.
So go ahead, Molly.
I'll say that I know this may come under the category of easy for me to say because I'm not in the situation, but I think that what I would recommend is that you really have to call the person on that. I don't mean that you can do anything right at that second in front of the resident, but in a private space, you would want to that you overheard the comment. You want to say how uncomfortable it made you feel. You would want the person to come to not doing that again. Now, I get it. This person may be somebody who's the administrative chain far above you, and that's an incredible risk for you to take. But I think that, generally speaking, my reaction is that you want to call the person on it themselves before you take it elsewhere. What do you think, Christa? And Toya has just written, I see a lot at night and on the weekend.
See, there's kind of several dimensions of this. So, the action asked a little was, was it in front of a resident or it was out the resident and in front of them? That's abuse. Yeah. That's pure abuse, and that legally must be reported. Mm-hmm. You went to the person, but it doesn't really matter. It has to be reported. That's just verbal abuse. It's also, it's very disrespectful. I think asking the person, I think, Molly, what you suggested, the person saying X, Y, and Z about, can you share with me where that's coming from? It sounded like you were frustrated. It sounded like you were angry. What's going on? And approaching it that way, usually one-on-one is best. There isn't a change in behavior, or it needs to move, because that creates that deviates from a resident-centered approach. And it says to me, especially if there's a lot of that going on, people on a particular shift, telling me that there are a lot of unhappy people who don't really want to work in this place anymore. Maybe tired of the residents, and then it's time to move on. Because creating that's toxicity. It gets water.
And Christa, you've both spoken a lot about risk in making change within an organization, and an element of bravery that comes up here for the staff member who sees things. And it was also mentioned about allies. So I would look to see who are your allies in the organization, who is the compliance officer. This does come down to abuse. It is reportable, and you need support in that.
Yep.
And frankly, if you take a risk and don't get the support and these kinds of circumstances, you need to ask yourself whether you want to continue in a toxic environment, is what I would call it. And if you choose to continue or not continue, you still have the right to report this to other channels. Ombudsman, state, whatever. But there are other, administrator, whatever. There are all kinds of venues for discussing these things, but we don't have to tolerate toxicity in the workplace anymore.
Right.
Thank you. Thank Molly and Christa and Deirdre. In terms of support, remember we do have the listserv, the national listserv that you're welcome to join. People on the call and any nursing home social service workers welcome to join to give each other support and to share ideas. With that, I'm going to have to conclude today's webinar. I want to thank everybody for joining us. I will be posting the handouts on the website, and the recording from today will be posted tomorrow. So thank you very much for your time and attention. We look forward to your comments in the evaluation form. And people who are on this call will receive an emailed certificate of attendance. Okay. Thank you much, everybody. Our webinar is over.
Thank you.
Thanks, Margaret.
Thank you.